So thank you so much for joining us tonight. I'm really excited for our open forum. A few housekeeping items to you guys that have already joined. Um, we are, as Elevation, starting a hands-on Shockwave lab series. So the first one is in Pennsylvania next week, but we're going to try to move those around the country. So I just want to let you people know we're taking technicians, vets, people who are interested in the product, people who own the product, just for a day fun event. Um, Also, if anybody has a fun case or knows of a fun case with the piezo wave, I am still in need for a November 20th forum host. Okay. And then I know some of you guys are still at work and or trying to feed families, and we totally understand that. But if you could please mute your microphones. If you do want to jump in with a question, great. We want this to be interactive. I have the chat open too, so we can answer questions through the chat, or you can ask Dr. Huntingford um, during or after her talk. But with that, I'd like to introduce, exciting to have Dr. Janice Huntingford here. She graduated from Ontario Veterinary College and is certified in chiropractic, acupuncture, rehabilitation, and pain management. She is a board certified DVSMR and does a lot of teaching out of her practice in Canada and for the CCRV courses. And from there, I'll let Dr. Huntingford take it on. Thank you for your time.
Well, thank you so much, Cindy, for that introduction. Cindy had asked me, if I had an interesting case, and I'm sure, most of you are probably familiar with treating Achilles tendon cases, and I am going to go over how to do that. But I had one very interesting case that had an Achilles tendon problem as well as a pretty severe gastrocnemius tear, and so you'll see how that comes about. But I do a lot of teaching. Uh, I'm an assistant professor for the Chi University in Florida, so I do a lot of their international programs. I teach in Canada, I teach in China, I teach in Taiwan, I teach in Korea. So they really have sent me a lot to Asia, but I have taught in Chicago and all over the place. So and I'm always happy to have things that are interactive. And so if you have a question, by all means, unmute or put your hand up, and Cindy will certainly see that if I don't. And I'm happy to answer the question. So we'll go on to uh, our interesting cases and stuff here. So before we got into the cases, I always like to talk to people about some of the basic terminology for muscle and tendon injuries. And it's very interesting that so much of our body and our patients' bodies are made up of muscles, but we don't really have, like, we have ophthalmologists and we have orthopedic surgeons, but we don't have really muscle specialists. And there's a lot of myofascial interaction and a lot of interesting things that happen with myofascial pain and that we sometimes are not aware of. Now, I graduated a really long time where muscles were really just the squishy bits that you pushed aside to get to the bones, which were the important thing. But now, at least, specialists in my field in rehabilitation, sports medicine, are a lot more interested in muscles. So here's the question, what's the difference between a strain and a sprain? Well, a strain is actually what happens to a muscle or a tendon. A sprain is what happens to a ligament. So we're not talking about ligaments today, so I'm not going to talk about that. But by definition, it's damage to a muscle or its attaching tendon. That's what a strain is, generally caused by strenuous activity, although does not have to be in our patients, and we'll talk about that, because it can be accomplished just during the course of normal daily living. And how do we treat these guys? Well, we grade them, and then what grade they are determines uh, the course of treatment that we use, and it determines the healing, and it's going to guide our treatment. So I'll show you what I mean. So when we have a tear in our tendon or our muscle, and this tear is being demonstrated at the musculocutaneous or the musculotendinous junction, and that's one of the more common places that we will see tears. And we will have damage to the blood vessel, obviously local bleeding, there may be some bruising. And a lot of times we're going to palpate a thick or firmer tissue. And there's going to be pain on palpation, right? Because there's irritation of the nerve endings. So, how do we grade these strains? Well, grade 1 is going to be pain only. And we have, in that case, we have mild damage. There's going to be less than 5% of the damage of the muscle fibers that are damaged. And we're going to have still some pain on palpation, but everything is really still intact. If we look at it with a musculoskeletal ultrasound, we can see some hypoechoic areas, and we will also see some interesting disruption in the pattern fiber, but generally it's going to be less than 5% if it's grade 1. So there's going to be minimal loss of function and strength, and that's going to take about 2 to 3 weeks uh, before it heals. Now, grade 2, and this little thing sort of shows you the differences. Grade 2 is going to be greater than 5% torn, but not a full tear. And we're going to get some loss of strength and function. And that's going to take a good 2 to 3 months to heal. They may come back to normal function. So it's important to figure out what type we have. And then grade 3 is going to be a complete rupture of either the muscle or the tendon, such as a gastrocnemius muscle or a tendon tear. And you can palpate these very easily. A lot of times there's going to be a hematoma and bruising, and you'll get that if they're acute. If it's chronic, what you may find is all that you're going to palpate really is fibrous tissue. And you're going to find out that your muscles do not stretch as well. So, for example, with your gracilis, we know about gracilis fibrotic myopathy, and that's usually starts off as an injury to that muscle. Now, in some of these cases, what will happen is that the muscles will be able to be fixed
Bye.
surgically, and in other cases, we can simply treat them medically, and we can certainly treat them by using some of our modalities. And we'll get a little bit more into that in a bit. So, what does our healing look like? Well, when we have, if you see here, we have our little muscle injury progression picture. So pre-injury or healthy tissue, you see all kinds of nicely, you see the muscle fibers all very straight. They are all going parallel to each other. And so that's a healthy tissue. If you have a strain in that tissue, where it's injured, you will get disruption, and eventually you'll get some scar tissue. And what does happen when you have scar tissue is that you do have a risk of re-injury. And also, if you're checking range of motion of these muscles and of your joints, what you'll find is you'll find a decreased range of motion, because our scar tissue leaves our muscle a lot weaker and less flexible. So healing, when we're gonna lay down this unorganized fibrous tissue, and that's just how it's going to heal. But if we have enough stretching, proper blood flow, then we can organize it so it will heal in a linear fashion. And sometimes we have to do things that piss off the tendon or the muscle, as I say. In other words, we have to do a little bit of micro trauma to get it to heal in the direction that we want it to go. The important thing to realize is that with these soft tissues, they're never as strong as they were originally. They are always going to be a lower strength than they were. Tendons, for example, even though they're totally healed, are really only going to have 79% of the strength that they had initially. And remember, you want to do a lot of the stretching, a lot of manual therapy with these guys, because that way you're going to decrease the chance of injury. So just as a reminder, because we don't always think about this or remember about how this works, we're going to talk a little bit about the anatomy of the Achilles tendon. So our canine Achilles tendon, also known as the common calcaneal tendon, is really made up of tendons from 5 different muscles. We have and I like to think of it of 5 different muscles, but really sort of 3 tendons. The gastrocnemius muscle, its tendon, the superficial digital flexor tendon, and then the conjoined tendon of the biceps femoris, semitendinosus, and the gracilis. Now, our conjoined tendon inserts on the medial aspect of the tuber calcanei. The superficial digital flexor is on the caudal, runs along the caudal surface of the gastrocnemius, and where it broadens into a cap to form on top of the tuber calcanea, and there's a little bursa that's under there. And then our gastroc, which is where most of our injuries do occur. And there's the medial and lateral heads of the gastroc, and they insert on the proximal end of the tuber calcanei. So here is our little gastroc muscle. You see we have the medial and lateral head coming from the fibella of the femur, and they're all going to insert down on our tuber calcanea. So that's what our gastroc looks like. And then this is just showing you how these all come together. So BF is biceps femoris, ST is the semitendinosus. We don't really see the gracilis in this particular picture, but all of those guys come down to the conjoined tendon. And that's the little thing in black above the yellow, which is the superficial digital flexor. So that if you think that the deep digital flexor is part of the Achilles tendon co- um, complex, you're incorrect. It is not. It's only involving the superficial digital flexor. And so, what happens when we have an injury? Well, this is a schematic showing normal, and the orange is obviously the gastrocnemius, and they spelled gastrocnemius wrong in this little picture. Um, and the purple is the superficial digital flexor. So when we have an injury only to the gastroc, we get this crab claw situation, which you can see circled there. If all of our tendons are torn, we get a plantigrade stance. So how does this happen? Well, trauma is going to be a very common reason. Trauma falls, lacerations, causing acute tears and ruptures, and causing overstretching, where you can get sudden or forceful movements, repetitive strain, that kind of stuff. So we do see this in our canine athletes. But also, this is a really big one that we in rehab see, and a degenerative condition, right? Age-related wear and tear or underlying weaknesses. So we can get weakened tendon, for example, if the dog has Cushing's disease, and that can make it prone to rupture if you're hypothyroid. So we do see certain breeds of dogs, like large active dogs, Labrador retrievers, Dobermans, they seem to be a lot more susceptible to Achilles tendon injury. But I see a lot of these degenerative Achilles tendons, and some of these old Labrador retrievers, they have these very, very flaccid tendons. You look at them, they have a little bump on their calcaneus. They've had some chronic issues there, and their tendons sort of feel like wet noodles. These are the degenerative conditions. Now, no one is going to do any surgery on these old dogs with degenerative issues with their Achilles, but I can tell you Shockwave works really, really well to help tighten up these tendons for these old dogs. So what sort of symptoms do we see? Well, obviously Jan, they're lame, right? But it's going to be difficulty or unwilling to bear any weight on their effective leg. If it happens very acutely, these dogs come in to see you immediately, they're going to be three-legged lame. And there'll be a swelling or thickening around the Achilles tendon. And if the gastroc is really ruptured, you'll be able to palpate this. The gastroc has all sort of thickened and folded up on itself. And you'll also get either sort of a dropped hawk, a totally dropped hawk with a plantigrade stance. If we have both the common calcaneal tendon involved, the gastroc, if all the tendons are gone, then we're going to get a plantigrade stance. But if our superficial digital flexor tendon is intact, we get this crab claw. So those are some of the symptoms we see. How do we diagnose it? Well, if we do a very good physical exam and assessment of gait, and I'll show you some of these dogs, range of motion and palpation of the tendon. You can do this pretty well by looking at the dog and palpating it. So here is one of my patients. This dog has bilateral tendon issues, but this would be what we would call a crab claw, and we'll see him walking a little bit later. But you can sort of see here, this is our very thickened tendon right here. And this was a chronic condition in this particular patient. Oh, there we go. We do get to see him right now, but we don't want to listen to him, so turn that off. So unfortunately, this dog ended up with this condition. I mean, he does not look that old, but this is a 7.5-year-old overweight Labrador Retriever. Started to have very strange gait as far as the owner was concerned, and he's walking like a bunny. The owner says to me, and my veterinarian X-rayed him and couldn't see anything and didn't know what was wrong with him, so sent him to see me because he said, there's actually nothing wrong with your dog that I can find, but maybe they can find something else. So if you see a dog that looks like this, and that has this kind of a stance, just from listening to me talk and remembering what this dog looks like, you can say, that ain't right. Dog shouldn't look like that. So even if we think our x-rays are great, which I did see this dog's x-rays and I didn't think they looked great. But that's what this dog is. And this is a bilateral issue. This dog was, anybody could probably guess, also hypothyroid. Yep. Okay. So here's just another little thing sort of showing you how this works. Obviously, A is going to be our normal. B is going to be our preserved superficial digital flexor tendon. And then if everything is ruptured completely through here, it's going to be our plantigrade stance. And that guy did have a lot of laxity in here of everything. And well, this is him again. It's just a little bit of a different picture. I must have really liked this dog to put this many pictures of him in this presentation. Anyway, so here's a closer look at our crab claw feet. Remember, again, partial, the SDF remains intact, and there's our plantigrade where they don't. You would be surprised at how many people do not know exactly what this is. And I'm really glad that all of you who are listening to this now know what's going on with these patients. So the other thing that helps you, obviously watching the dog and palpating him, but when we are feeling these strains and trying to grade them, is to palpate the muscle belly and palpate the tendon, stretch the muscle. Is there an inability? Can we get that gastroc muscle to stretch? And remember that if you're stretching a muscle, you're doing the action opposite that it does when it contracts, right? So that's what you need to do. And tendinopathy, you're going to get pain with pressure on the tendon with stretch. So that's one of the things that you'll find, that in the acute phase, you get your pain right away. So you're not going to be confused about that. But if it's a chronic one, some of these old degenerative ones are really not painful. But some of them are, because they started out, they might be chronic now, but they may have started out as an acute injury. So how do we make the diagnosis? Well, we know that we can make the diagnosis based on clinical signs and palpation, but it really would be nice to have some imaging to back up what we think. And I do musculoskeletal ultrasound. Not everybody does, but it's a good way to look at these. Certainly, radiographs are going to be helpful, and I've got a couple here I'll show you. Obviously, an MRI um, is going to give you the answer, but you generally should not have to go to an MRI to be able to diagnose this problem. So here is a typical radiograph of a dog with an Achilles tendon problem. So let me see if I can get my little pen here. So here's our calcaneal or tuber calcanei, and you can see this large bump area, which you'll be able to palpate. You'll also see that this tendon is very thickened in through here. I can't appreciate it on this one, but if it's chronic, oftentimes you will see calcium deposits, and usually it's kind of in these areas. But this goes like this tendon is very, very thick as you palpate it up here. And it would be interesting to know how that muscle there feels. So take that off, and go on to the next thing. So this is just showing you more. I guess I should not have zoomed this in so much, but this is an ultrasound of a normal Achilles tendon. So that's showing you where the gastroc is, the superficial digital flexor, and the common tendon. And there's this lovely bursa here, and this is the tip of the calcaneus. And this is in a cross-sectional view, which is pretty much showing you the same thing. This one is relatively normal. I think this is a hypoechoic area right here. So there may be a little bit of issue with this gastroc here. And this is again, this is an older one. So this is showing you a view of a grade 1 strain. This is a hypoechoic area here in the gastroc tendon. And this is actually one from the case that we're going to have a look at. And this is the gastroc tendon of Cooper, who we'll have a look at Cooper's information. And we have very nice tendons here. This guy here has some disruption. He's not ruptured, he's still there, but he does have some fluid building up in there. So, how do we treat these dogs? This is always an interesting question. So can we treat them with conservative management? Do they all need surgery? Well, if you have a complete rupture, surgery is usually what's needed. And they will do some very interesting surgeries with pinning and toggles and things like that. And after they come out of surgery, these dogs need an orthotic. Now, my preference, because the surgeons who do these are going to put them in a cast. They're going to put them in a bivalve cast. But what I like to do is if possible, when the dog is out having its surgery done, I'd like to do a cast that I'm going to be able to have an orthotic made from, that you basically put it on and take it off before they put on their bivalve cast. But if you get one that has a bivalve cast, they're going to want to leave that thing on for 4 to 6 weeks. And I will always tell them, well, we'll leave it on for 2. I'll take it off and check the leg and do some rehab with it at week 1 and beyond. But by week 3, I'm hoping that I have my orthotic in so that I can put that on, because we do have some older surgeons in our area who still say, put this cast on, don't let the dog do anything for 6 to 8 weeks. And that's not going to be right. Because what will happen is the dog will never have a normal leg and never have a normal gait because you're going to heal with some fibrous tissue. So we do need some immobilization, whether it's a tensor bandage, whether it's an orthotic, we need something like that. Most of these dogs, I also put platelet-rich plasma in them because they have holes that I can see. They have disruption. I can put some PRP in there. I will also do shockwave on these dogs. For the laser therapy, I might use that on the muscle, not so much for the tendon. And I really, of course, do a lot of rehabilitation on them. So what kind of prognosis do we have? Well, after care, and this is really more post surgery than anything else, it basically is going to include kind of restricted activity. These dogs should be going out for bathroom privileges only, but there's still some things that you can do, some range of motion, that kind of stuff, and we'll talk about that in a few minutes. Remember that complete healing of the tendon is going to take up to 12 months, and it's only still going to be 79% of the function. And rehabilitation is what we need to restore the appropriate range of motion of the tarsus. And we kind of need to know what the normal range is. It's about 135 degrees of flexion is what you're going to get with these guys. The potential complications are going to include re-rupture or breakdown of the surgical site, it should say there, if the dog's had surgery. But the outcome is generally very good. 75, 95% of the dogs are going to make a full recovery. Okay, so now we're going to talk about Cooper, who was one of my very interesting cases. And Cooper's 11-year-old golden doodle was presented for an acute injury of the right hind leg. The referring DVM thought the dog had a total Achilles rupture, recommended surgery, got some quotes for surgery from some of our local orthopod, and the client basically could not afford that and came for a second opinion to say, do we really need surgery? What can we do? What else can we possibly do for this dog? Or do I have to spend 8 to 10 grand for this? So this guy was kind of a shy dog, 11-year-old female spayed, golden doodle, 15 kilograms. It was unknown how this injury occurred, but when the dog came in to see me, he was non-weight bearing. He is a she, was non-weight bearing. But when we put the leg down, she would scream and appeared very plantigrade when she would sort of put the leg down. But it was hard to tell. Very, very severe swelling and bruising of her gastroc muscle and the lower leg. So I said, well, I need to do some musculoskeletal ultrasound on this so I can evaluate the muscle and tendon. Because if there is a total tear, there's not a lot that we can do. We can put PRP in that. We can immobilize it, but a lot of times those really need surgery. But this is what she wanted to know. Was there a chance that we could get away without surgery? Here's what this looked like. This poor little dog. So here's our Achilles, very, very bruised. It was all bruised up in through here and also onto the front of the leg. And you can see from the medial side, this was all very, very bruised. And this poor dog was pretty painful. This was what this dog's x-rays looked like. Now, we didn't take these x-rays. They were sent in to me, but if you look here, you can see the thickening of this tendon here, but also this should sort of be a space, and there's something here which is really the tendon has gotten very thickened all through here because um this is going to be an injury of a lot of these tendons. So then we did an ultrasound on this. Here in this area, this does not look too bad. This is pretty much normal. This looks like pretty much normal muscle. Now we're getting in through here into where the some of the tendons are coming in, and these don't look 100% correct. These look like they have more um, more areas where they have lost signal, so they're more hypoechoic. And this is right over the area that was the most painful. And this is a total disruption of these tendons. Now this one here, this is our gastroc, and this one had a lot of disruption. We still have the peritoneum coming through here. We still have it here. We have a lot of disruption here. This tendon here is disrupted. Here we have a hypoechoic area, and you can just see that this is not a nice linear structure. But when I looked at the very ends, there was no true ruptures in there. And this is just showing you cross-sectional how this looks. And this was the area of the hematoma in the gastrocnemius tendon. And this was our view that we were looking at. I love this. This is such a beautiful picture of this tendon coming over the tuber calcanei. And it doesn't look too bad there. It's thickened. Yes, there's some fluid in there. There's some holes in there. Um, and there's some disruption right there, but it hasn't totally avulsed. So I was happy to see that. And I basically said there's a lot of muscle and tendon disruption here. There's a hematoma in the muscle, but I still called it a grade 2 rather than a grade 3 strain, but it was getting pretty close to a grade 3 because there was still intact tendon. So I said, well, surgery might be the best thing for this dog, but why don't we have a look and treat it and see how we do? Because there was going to be no huge issue at this point with all of this bruising of rushing this dog to surgery based on what I could see on the ultrasound. So here's what I'd recommended. I recommended that we certainly do some pain control on this dog, that we put on a support bandage, and I was recommending that we cast it so that we could have an orthosis for this dog because I really thought that would be the best way to get 100% healing with it. And but pain control, I wanted to do shockwave on it. I figured that's going to help the muscle, that's going to help the tendons, and I really would have liked to have put platelet rich plasma in there. And then at some point, got the dog in my underwater treadmill to strengthen those muscles up and do some rehab exercises at home. Now, this is what I wanted to do. And as most of you who've practiced for a while know, there's always what you want to do. And then there's plan B because the client didn't want to do all of those things. And so we'll talk about what we actually did. But why am I recommending Shockwave for this? Well, because I'm recommending this for mechanomodulation. If I can get some mechanical stimulation of this area, I'm going to have the dog release its own stem cells. It affects osteoblasts and chondrocytes and tenocytes. So I'm not quite so worried about osteoblasts, but I really want to get my chondrocytes and my tenocytes activated. It's going to increase local blood flow, and really we want to increase our cellular activity because we want to change our release of nitric oxide. We want to, this is transitional growth factor alpha, nerve factor kappa beta, pro-inflammatory cytokines. We'd like to reduce our inflammatory cytokines and reduce substance P and prostaglandin E2. So we want to alter those. Now, it's not such a bad idea to have a little bit of these in there because a small amount of inflammation makes the body turn on its own natural anti-inflammatory system. So this is really what is happening, and we'll get a transient analgesic effect of our afferent nerves. Now, what kind of recommended settings do we usually use for a dog like this? Well, I use the 10 sound head frequency 8.1 and about 1,000 shocks. Depends on which machine you have exactly how these work, but that's pretty much the standard for this. So what did we do with this dog? Well, the lady said, okay, you can put a bandage on the dog. And I said, all right, we'll do shockwave twice a week for 4 weeks on this dog, and we're gonna put bandage changes on it. We have to take the bandage off to do the shockwave, and I wanted to do that anyway. And although an orthotic was recommended, the owner said, no, I can't afford it. Should have been done, but it wasn't. Hinged orthotics that are dynamized in cases like this are going to be better. So, what do I mean by that? Well, I'll show that to you in a bit, but really it's a type of orthotic where you can change the level of the degree of weight bearing that the dog's putting on that feet. So here's what we did: twice a week Shockwave. After our series of Shockwave, the dog was about 75% better. And the owner said, well, I'm not going to do anything else. Shockwave is the only thing that I want to do. I wanted to have a look at this dog again with the ultrasound, and the owner and I said, I would just do it just to look at it. I won't even charge you for it. And she said no, because she did not want to have to sedate the dog. And you had to sedate this dog in order to do that. I'm like, okay. Um, in my opinion, PRP would have been a better choice to do right after the Shockwave series instead of just home exercises. But the client couldn't afford it, so we didn't do it. But the interesting thing is that this dog, even without PRP, healed very, very well. So I think we can, Shockwave is often a part of what I'm doing for these dogs, but it is also um, obviously a very good treatment. And the thing about this dog was it wasn't just the Achilles tendon. He had a very severe gastroc hematoma, and this really helped a humongous amount. So we were talking about what like braces. So this is one of our dynamic braces. This brace, when we look at it, you can um, increase the amount of flexion that the dog is getting. So you can increase it usually on a weekly basis, but there's a little wheel in there so you can turn it and tighten it and loosen it and do all of those kinds of things with it. So how does this work? So this is sort of a rule of thumb, I guess. And somebody once told me rules of thumb are really just for thumbs. So not really for all of our patients, but it's a good thing to think about. So if we have a grade 1 strain, what we would use would be a soft brace, just a neoprene, something to give the dog some support. If we have grade 2 and grade 3, we really should be using an orthotic, so we have no joint movement for 6 to 8 weeks, and that's common post surgery. And we would want to have it dynamized. So what does that mean? That means that the steps are going to be taken out of the brace at regular intervals to increase the stress on the Achilles. In other words, to increase the weight bearing and also increase our range of motion. And how much do we change it by? Usually 10 to 15 degrees of flexion as healing occurs. And then we wean them out of the brace altogether. Although we will, with our dogs who are athletes, we will put this on for high activity. And remember, our normal flexion is 135 degrees. We don't want to really get it more than that. This is just another one of our patients. Dobermans, very, very common to injure their Achilles. And this is a lovely little brace that he's wearing. And here, um, this is another example of a brace from another company. Just wanted you to see how this works. Some of these things, if the dogs need totally rigid orthotics and not move at all, they'll have a little foot part in there. And many of them have a foot part that you can take off. So it just depends when the orthotist looks at this and has a discussion with you. And we look at what's going on with the dog, which of these braces is going to be better for him. So, so here's where we come to sort of my few rules of thumb. What am I going to do? This is based on tissue healing, right? Acute phase with healing. This is week 1 to 4. So this is either week 1 to 4 after maybe a severe injury, or um, perhaps after surgery. Okay. You can do passive range of motion, joint mobilization, and massage. Remember, these dogs usually have some kind of brace or support. So you have to take that off to do that. Your shockwave is done twice weekly, and remember, you should clip before you do this for these guys. You can do laser on the muscle. If you're doing shockwave specifically for the Achilles tendon, you're going to be shockwaving the tendon. Don't laser it as well. You can use laser on your muscle, but don't use it on your tendon at the same time. You can add PRP, but if so, you're going to wait 3 weeks to start shockwave. Like if you give your PRP first, then wait to do shockwave. If you do your shockwave first, that's fine. Then put your PRP in. Your therapeutic exercises initially, there's basically stretching, passive and active, a little bit of static weight bearing. So isometric exercises. What I mean by that, you get the dog to stand, and your isometric exercises, you're basically going to push up and down on the dog's pelvis. So it's bearing a little bit more weight on that. And you're going to encourage weight bearing in that splint. And then week 5 to 8, this is the healing phase. Again, you're going to do passive range of motion, joint mobilizations, massage, and scar therapy if there was an injury. At this point, you can really laser that muscle. And I'm going to start my underwater treadmill for most of these guys at 6 weeks. If they've had surgery, I will check with the surgeon first. But in general, 6 weeks is where we want to be looking at doing this. And what kind of therapeutic exercises? Well, stretching of the hawk is really key. And I like to use the therapy ball, rock the dog back and forth. I'm going to add some core exercises, proprioception, three-legged standing. I'm going to put the paw on a decline. I have some pictures of these in case you haven't seen them. At 6 weeks, backwards walking and then backwards walking down a hill. I have 6 weeks there. I might do it at 6 weeks. For most people, they're probably going to do it at 8 weeks, but you really have to decide if you know what's going on with the healing. And if I'm wondering, I can look at it with my ultrasound and see where he's at and go, okay, yeah, we can do this. By 8 weeks, generally, you can do incline walking uphill and a little bit of dancing. But dancing, I might wait till the next phase in order to do that. So this is when we talk about core exercises, this picture on the right is a plank. And you start with these closer together, and eventually, just like you doing a plank, you end up stretching these little pads out further. So the dog's doing a great job of planking. And this is just a dog on a rocker board. So we're trying to work some of our core, but we're also working strength in our hind limb muscles. So here's our 8 to 12, or our strengthening phase. This is really when our underwater treadmill is going to be the best, but we have to wait to initiate this phase when there's no swelling, when there's no inflammation and no spasm on range of motion. Because our range of motion needs to be comfortable, and you continue dynamizing the brace, and eventually you're going to go to a neoprene support. So manual therapy, we're going to do passive range of motion, joint mobs, massage, underwater treadmill. Those are the things that I like to do with these. And some of these exercises, what are we going to do? Backwards downhill walking and dancing. This is really 8 to 12 weeks is really where I like to put in dancing, and probably more backwards down the hill. Cavaletti, in case you're not familiar with those, I do have some pictures of those. Zigzag walking, theraballs, and Bosu. So this is the little dog on a theraball. And having them do sit to stands on a theraball is really a good thing to do. This dog was very talented, this little dog on the left, and he could walk all the way around that ball. And on the right, this is a Bosu. A Bosu is a half ball, and usually you can see these, you can find these in your gym. They will have them for us to work on. The one that I have, I got at a garage sale. Someone was done exercising and selling their Bosu ball for $5. So we use it for therapy for the dogs, and you can use it with this side up, or you can use it with the flat side up. When we're using it flat side up, it's really more like a rocker board that we're using it for. But we're doing this for core and to increase our range of motion. And then cavalettis, for those of you who don't know what cavalettis are, they're really just poles that the dogs walk over. I am Canadian, so this is a group of cavalettis that we made. And these were made out of PCV pipe and red hockey tape. The red hockey tape is the most important part. But anyway, depending on which team you're rooting for. And wha- ball exercises that we like to do. Basically, we end up having the dog put her legs up on the ball, and then we'll have it rock. We have them rock back and forth. I think this dog's fairly well trained, and usually she will get up and put her feet up like she's supposed to. But she looks like she's not really happy about doing that. So Dana's going to have to pick up her legs and put her up on the ball. And that's pretty normal. Usually that's what you have to do. But this is the rocking back and forth. So this is going to be like we talk about dancing, and dancing would simply be instead of supported on a ball, you're going to be standing up and holding the dog and dancing back and forth. I would much rather do this on a ball. It's more controlled, and you also are really controlling the front leg of the dog as well. So I am very happy to take any questions at this point.
Does anybody have any questions? That was great, Dr. Huntingford. Any questions? It's going to be a shy group. Well, Cindy always has a question. Oh, Megan has a question. What is your favorite brace to use?
Well, I am Canadian, so I'm Canadian, so I deal with Jeff Collins from Canine Orthotics, and he does a great job for me. And particularly with all of the issues with the Canadian US border, that I'm very happy to use that. I have, also done orthopets and some of the ortho vets one, but I'm very happy with Jeff from Canine Orthotics, and he's out in Nova Scotia.
So my question is PRP and Shockwave. Everybody does it different, and I know you have your reasons. So can you explain the 3-week wait period for Shockwave or
So I wish that,
before?
yeah, I wish that I could tell you that someone has done a
No,
paper
I
to
know.
say,
I know that.
don't do shockwave here, do shockwave there, do your PRP first, do your shockwave first. The reason that I recommend, if we put in PRP, that I recommend you put in PRP and wait for shockwave is because I am trying to give those little platelets enough time to release all their growth factors and do what they're going to do before I start doing some mechanotransduction. Could it be sooner? Maybe you could do it after a week, but I guess it's probably because I'm trying to be super safe. And
Yep.
that was sort of what I was taught. Although when I went looking as to why that was the case, I can't tell you that anybody has a paper on that. But it's the same group of people who also said, well, you can't use meloxicam and you can't use laser right away with shockwave. Same group of people. And both of those things have been studied and proven to be false. So, but what I do tend to do, if I'm doing platelet rich plasma, I will do PRP and laser because they're synergistic. And then I will wait 3 weeks and then I'm going to do shockwave.
Okay.
Now, if in the case of Cooper, I would probably have shockwaved that gastroc muscle because I'd put PRP into the tendons. Putting it into the muscle, I'm not sure that that would be as helpful as I might like, but I would think you could probably shockwave that at the same time. I just don't want to put it in the place where I've just put my PRP. But I think that case is very interesting because although I think that the dog should have had PRP, the dog seemed to have healed up quite well without it. I mean, I haven't seen the dog in a while, but I have called the lady and she said, "Oh no, he's 100%. And besides, he's 11 anyway. I didn't want to spend any more money on him because he's 11 years old." I'm like, okay,
Well,
whatever.
it's pretty amazing. He was smart. He must have been a smart take care of himself dog because of otherwise he would have re-injured that with no protective brace. I mean,
Yeah, yeah. Well, I mean, we did put a bandage on there, but it was just a bandage. It wasn't a splint that we put on there. It was really more just of a neoprene type thing. And she did keep him fairly. Um, she kept him fairly quiet,
and he was a good boy, so.
and he
Um,
was a good dog.
so Megan would like to know, for a chronic degenerative case, how long would you generally do shockwave and at what frequency of the treatments? She sees a lot and would like to figure out what's the most effective
Okay.
spacing and use.
Yeah, so I will do a course. If I for those chronic cases, I will do a course of twice a week usually for 6 to 8 treatments till I'm seeing some results. And then I'm going to wait about a month or so, and then I'm going to see the dog back and see how they're doing. And I may decide to then do it again. I think with these chronic degenerative cases, like the question is like, what's causing the degeneration? It'd be nice to
Mhm.
know so that we could stop that, because although shockwave is wonderful and it will help with these tendons and it may help with the degeneration, it's not going to cure the problem. So we sort of have to look at what's going on. If we are unable to find this, if it's some kind of immune mediated issue, if it's something that we can't figure out why these things are degenerating, then I might just have that dog in and do a couple of shock waves. I might have it come in every 4 to 6 weeks and have in that one week do 2 sessions of shockwave and kind of go on from there. And I'm not sure if that's right. Cindy might tell me that's not right. Jen, why are you doing that? But that's what I find is helpful for these dogs. So, and it's really, and there are ones that need it more frequently, and then there seems to be ones that need it less frequently. So I'm not
No,
sure I've helped you, Megan.
there is no right or wrong with shockwave. It's evolving every week. And yes, I have seen different dogs with similar chronic issues need very different timing. I don't know why, in that case.
Yeah.
Amanda, what is your favorite supplement for tendon injuries? I'm thinking in terms of TCVM treatments and usually do JT tendon ligament, but also love standard process. What do you use?
So I'm unable to get standard process in Canada. So I will use tendon ligament from Jingtang for these dogs. I do put all of these dogs who have Achilles issues. I put them all on tendon ligament. But then there's a couple of other Chinese herbs that I might use as well, depending upon the pattern. And I didn't put that in with our friend Cooper. He did go home on some tendon ligament, and there was another Chinese herb that I did use on him as well, more for inflammation. It was a con herbal product called Benefit Hips and Knees, which is really probably more for joints, but it does have some effect on tendons and ligaments as well. And now, other than that, the other supplements that I really, really like for joints and osteoarthritis, because these dogs are going to have this issue. I'm a huge fan of undenatured collagen type 2.
Great. I know in the horse world, we seem to use a lot of tendon ligament, a lot.
Yeah.
Um,
Now, I shouldn't really tell you this, but I used it on my husband. I had him mix it with peanut butter and put it on his toast every morning for about 2 months when he ruptured his meniscus. Seemed to help.
Seem to help. Maybe that'll help me. I just had an
Yeah.
MRI and think it's a meniscus. We'll see.
Oh, geez.
Awesome. Any other questions, thoughts, comments? Lots of great information, Dr. Huntingford. I love it. Thank you so much for your time and energy. And I will be seeing you and Chi in a few weeks. And everybody says thank you and we appreciate it.
Hey,
Awesome.
bye.
Have a good night. Thank you, everybody. Appreciate it.